So I'm here with Jerry Radich, and we're talking about CML, and I think another important question that we noticed is you have a patient on treatment and staying on course or switching therapy, which in my mind is a myriad of different stop points there. You've obviously made a first line choice, and then you're looking at a number of different things. And I think probably the most common thing I wrestle with is a mixture of intolerance and resistance, and the struggle of. I mean, you're looking for an agenda of maintaining the drug and the dose that's effective with a day-to-day side effect profile that's manageable. I think we focus mostly on response endpoints and milestones. And then those, of course, are myriad. What is it, 3 months, 6 months, 12 months, 18 months, and what depth of response? So how do we define failure? And when do we feel like what are the absolute, hard stops? You got to switch.
Yeah, so that obviously is a problem, especially when you're at a referral center. I'm at a referral center. One of the problems with having so many choices of tyrosine kinases is that the reflex to switch drugs as soon as you have any toxicity at all is very high, right? So a lot of times, you and I see the same types of patients. You have a patient who's cycled through 3 different TKIs for minimal toxicity and very quickly, and you never get an idea at all on whether this is a patient who has intolerance or this is a patient who just doesn't respond, right? So that's a mess, and there's no really clear way around that except to stick on something for a while. That being said, I think if you're pretty confident someone's been on a drug, I think there are a couple of endpoints that give me pause. If someone hasn't had a response of, at least greater than 10%, lower than that, by 6 months, I think that's bad. You can make the argument for 3 months. I have made the argument for 3 months. But a lot of time in the setting that you're talking about, people have never had exposure to 6 months of drug constantly ever, right? So you really can't make that call. But if you really think that they've had 3 to 6 months of really constant exposure and the BCR-ABL isn't budging, I think that's a really bad indication of biology. It's hard to imagine that suddenly their disease is going to decide to become responsive to any other therapy.
And specifically, I think a lot of people use that hard stop of 10%. They don't take into consideration the patient's initial transcript level, which is an important point to make. I mean, you're probably the world's point person on molecular testing, and the lab, the results we get are standardized for the most part, but often the international standard is not well understood. And if a patient starts at a very high level, a 10% level of 3 months may be beyond what they need to have.
Yeah, and I think the other issue is that, we have a very long history in hematological malignancies of making really big cutoffs in sort of an idiotic way, right? So when we have an acute leukemia, we do a bone marrow, and their morphology is 3%, we say, hooray, they're in remission. If there's 6%, we panic, oh my God, right? And myelodysplasia, right? You have 90% blast, you're myelodysplastic, 21% blast leukemic. All that stuff is stupid, right? It's completely stupid, right? So you can't just say 10% yes or no. Like you're getting to, it really is the kinetics that drive everything, right? So you have someone who starts at like there, and by 6 months has gone down to there. Even if they've gone over 10%, if they go 11% to 9%, but it's taken them 6 months. That's worrisome, no matter whether you hit the cutoff or not. Someone who goes from 100% down to 11% really fast, that's pretty good, whether they hit that cutoff or not. So I think you have to kind of use common sense and look at this as a kinetic stuff, because if you are a tumor and you are really being exposed to disease, you are not going to suddenly change your mind that you are an unresponsive tumor and that, oh damn, I forgot, I'm supposed to be responsive, and then suddenly do
well
that. That's not going to happen, right?
Well said, yeah. I think we probably could agree that lack of a cytogenetic remission at 12 months is probably a pretty...
Yeah, that's. So 6, and then I'm not that excited about considering someone who doesn't reach an MMR a failure per se, because people actually do, pretty well. That's different than someone who actually gets into an MMR and then suddenly turns around and starts coming out of it, right? So in my experience, people do not get a response below MMR, turn around and go north of that, without bad biology, unless they've quit taking their drug, right? And I've never seen anyone on drug go back up and then suddenly, go yikes and then just get better again. That doesn't happen. So if you're below MMR, and if you're way below and are coming up to it, I don't think you necessarily even need to break MMR to start getting worried and thinking about second generation drugs. It's unlikely if you've gone from, let's say, undetectable up to towards MMR, which is going to be anywhere to a 2 to 3 log increase. Hard to imagine you get a 1,000-fold increase in your transcript level and that not be bad. Right, so I don't think you need to kind of wait and just poise until they instantly break MMR.
So going forwards, MMR, you got to be a little bit more generous and a little bit more patient on the way backwards. Losing MMR is a big deal.
I think that's it. That's telling you something, right?
Yep. And cytogenetic remission is probably a hard stop. And then intolerance. I think when you can't deliver the right dose of a drug for a patient consistently and their quality of life is poor, I think we sometimes sort of brace ourselves. CML therapy, it's a marathon. And it needs to go on for years. So physicians need to ask patients about toxicity, manage it actively, because that's a hard stop too. I mean, ask a patient about adherence, and if they admit to some poor adherence, you probably know that's probably just the tip of the iceberg. It could be much worse. They may not be taking the drug. Just as you mentioned, loss of response may often be because they stopped taking it or they had a toxicity. So we got to pay attention to that.
And I think the patient, a series of patients. Fortunately, not a big series, but I have had a series of patients where they were really intolerant to the drug, and it was mostly because of not side effects per se, but actually because of blood counts. So patients who had to take long windows off of therapy because their counts would tank and they could never get a dose. Those people, I think, while there is some transition that happens with low counts early on in therapy, these patients that stay with low counts forever and you can never give them anything, I think that's a bad sign. And I think that's a sign of early progression. And I think it's also a sign that if you can't really maintain them on any therapy with that, then you're just waiting for them to progress. And I've seen a number of patients who have been sat on given drug holidays for so long that when they do finally, go bad, they get into blast crisis.
I agree. I think it's disease biology that leads to exaggerated myelosuppression or persistent myelosuppression. Do you think we covered this topic? I think we got it.
I think it's a done deal.